Well, what did you do? You have older kids. You mind if we talk about, like, you have older kids? Can we?
Sure. I have an 11-year-old and a 15-year-old, almost 16.
So what have you done to?
So with my 16, both my kids, frankly, know almost everything you could possibly know about different drugs and their effects on the brain and how they impact the mind and the body. And they are very aware that, one of the problems with substances of abuse, and by substance of abuse I mean drugs and alcohol, one of the problems is that they all have effect on the brains that people like. They make you feel less anxious, less stressed. I mean, nicotine or tobacco is remarkably good at relieving stress and making you smarter. People function better oftentimes when they're smoking, right? The brain moves, their cognition improves. So, of course that becomes addicting, right? And so you have to remember that every substance of abuse has some sort of a positive effect on the brain.
Welcome, everyone, to the Whole Truth Podcast with John Levine. Here with Dr. Diana Martinez. She's a psychiatrist from Colombia whose research focuses on using positron emission tomography, otherwise known as PET, radio tracer imaging, to investigate the neurochemistry of addiction in the human brain. Her work uses PET imaging to detect the neurological changes that occur in drug and alcohol addiction, and whether these biomarkers for addiction are associated with the severity of disease and treatment response. She also uses imaging to develop innovative treatment approaches for addiction, and her education and training is from the prestigious Cornell University Medical College in New York, and it is an absolute pleasure to have you on the show. What is shaking, Dr. Diana?
Good question. Thank you. Thank you for inviting me. Thank you for having me out here. Just let me know what you want to talk about.
Well, I just picked you up at the train station. Let's give a little backstory. So we have a mutual friend, Dr. Allegra Broft. Dr. Allegra Broft was on the podcast as well. And that's how you and I got to know each other. She said, I know I've got another great doctor that you got to talk to. And I said, all right, let me hear. Dr. Diana Martinez. I looked you up and I said, all right, that's it. Give me her number. We got to talk. We talked on the phone. And I said, all right, I'm going to pick you up at the train station and we're going to do this. So I just picked you up at the train station, got to know you a little bit more, had a nice conversation, learned out you're a Texas vegan.
Of all things.
Yeah. I was a vegan for 7 years, so I know how that goes. But we're going to this is what we're going to talk about today. PET imaging. Neurological changes in the brain and the associated diseases. And then we're going to delve into medical marijuana.
Okay.
Which I didn't have that on my list. And then when we talked, I sent you a text message saying, hey, anything else you want to talk about? And you're like, how about medical marijuana? So that is on your mind. Did you bring in any medical marijuana that we should smoke on the show, by the way?
I didn't. Unfortunately.
Will you bring, because I think it's legal now, so can you bring some next time?
It's not legal now.
It's not legal? Oh, no, not recreational, medical.
Right. Oh, medical.
Medical, yeah. Well, I have a bad back, so
okay.
I'll just say...
Well, the criteria vary from state to state. So in New York, you wouldn't qualify in New York State for medical marijuana. I don't know about New Jersey. So New York has very specific criteria that you have to meet, and bad back isn't on the list.
Bad back is not... Okay, so you know what? We're not going to get into this too much, but I will tell you this. From being a real estate investor, I have a group of guys that we work together. An opportunity came along for medical marijuana and dispensaries in Massachusetts. And I am now involved in that. And that was about a year and a half ago. And that's up right outside the airport, Logan. Right. Amherst and the surrounding towns over there. So I do know a little bit about it.
Yep.
It's an interesting topic. There's pros and cons.
As there is to everything in life.
Yeah. But PET imaging. So what's PET imaging?
So PET imaging is a modality that we use where we can image the specific receptors and cellular targets in the brain. By using this imaging, we can look at different receptor systems or different neurotransmitter systems and get an idea of what is awry, for example, in people who have different types of substance use disorders or addiction.
It's a brain scan.
It's a brain scan.
Yeah.
And it's a specific type, so we can look at different neurotransmitters, and we can get a sense of what predicts treatment, what predicts relapse, or what might be a better treatment for addiction, better than the ones we have right now.
So what shows up on these PET scans? So are you doing PET scans for only people who have addiction?
We normally do PET scans of people who have addiction and compare them to people who don't have an addiction, so we can look at differences between the two groups. And then we look at the PET scans within the affected individuals and see if it predicts clinically relevant behavior like treatment response.
That's interesting. So the a normal, I shouldn't say a normal brain, but a brain that is not been, on drugs and all sorts of substances. What does that look like compared to a brain that has been on drugs and alcohol? Physical, is it like there's a physical difference, right?
There's a physical difference. So much of our brain imaging, the work that we've done in our lab usually focuses on the dopamine system, which people have heard a lot about, and what does dopamine do in the brain. And, if you go online and search dopamine, it'll tell you that dopamine does basically everything, that dopamine is in charge of, gambling and romance and eating and all these different things. And that's actually not entirely true.
So that's my problem after all?
Well, it could
I
be
have
everybody's
too much
problem.
dopamine.
Or too little. It goes both ways. In general, with most things in physiology, it's best to be in the middle and not too high nor too low.
Yeah.
So the thing that dopamine mostly does in the brain is it connects a particular behavior with a particular reward. So it's the thing that links two different phenomena in your brain. So if you are, I live in New York, so if you're a rat on the subway platform and you're sniffing around and you find like a delicious piece of muffin in a particular trash can, dopamine is the thing that links yummy muffin with trash can in your brain. And so dopamine also mediates what we call reinforced behavior. It means when that rat goes back to that subway platform, he's going to go to that particular trash can, right? So that behavior is going to be reinforced over all the other places that rat has looked. So he's looked under the stairs, he's looked at all these various places, but none of those were connected with the reward. It's dopamine as a thing in his brain that says, looking in this particular area or doing these particular things led to a reward, so do it again.
Okay, so the rat's walking down, he's gone through the process, he's looking, he sees the muffin.
Right.
Okay, boom, the dopamine hits.
Right.
Okay, so now he had his muffin, he's full, the next day comes, the rat's going, he knows where he's got to go.
Right.
He knows exactly where he's got to go to get that muffin.
Right.
Because the dopamine hit and...
Because dopamine made that behavior be more... Because, in the course of any day, a rat or any other individual has tons of behaviors, right? There's a million things that you do. So dopamine is a thing that says, no, this one comes first. This particular behavior comes first because it's connected with the reward that I want.
I ate a muffin this morning, by the way. Okay. Are you calling me a rat?
Rats and humans have some things in common. And
Especially me. You have no idea.
That could be. But the interesting thing about dopamine is if that rat goes back to that trash can and the muffin isn't there, so if you go back to your muffin store and there's no muffin, dopamine actually dips. It decreases, and it tells you that there was no reward when one was expected.
Okay.
So that's basically what dopamine is doing. It's constantly updating your brain to let you know what you need to do on any given day to get the things that you need in life to survive. Now,
yeah, that's amazing. So how does that relate to? So what kind of addictions do you see? Is it alcohol, and is it all types of addictions?
So when we look in the brain and we look at dopamine levels in the brain or dopamine receptors, sorry. So when we look in the brain and we look at dopamine receptors and dopamine levels in the brain, we don't see a big difference between different types of addicted individuals. So from a brain perspective or from a PET perspective, especially when we're talking about dopamine, alcohol, cocaine, methamphetamine, tobacco, and opioid addiction all look very much the same. And that's because what we think we're seeing when we look at dopamine is basically, you can think of dopamine as mediating a habit. So dopamine is a thing that makes you develop habitual behaviors, such as going to your coffee shop to get your muffin or to a trash can to get a muffin.
Right.
Now, as I mentioned, if the muffin isn't there, dopamine needs to dip. So dopamine levels need to change in response to the environment. They need to go up and they need to go down to tell you what to do. The problem that we see in addiction is that dopamine sort of loses its plasticity. It loses its ability to be nimble and to move around. And so what happens is you have a habitual behavior. Now, when you want to change that habitual behavior, dopamine is the thing that helps you change that behavior. So what we're seeing in addiction is when dopamine levels are not facile enough, you can't modify your behavior. So even though you have different rewards in the environment, you still choose the same old reward, whether it's a dose of cocaine that doesn't even reward you anymore over other things. So you need dopamine in your brain to shift between competing behaviors.
So the dopamine is not changing. Is that what you're getting at? You're saying that
it's sluggish. It's not responsive enough.
So once you do the alcohol, once you do these drugs, the dopamine rises, and then what you're saying is even if you try to get off of it, it's just not what's the word? It's not flexible.
Right.
It's just kind of like I don't want to say set in stone. It's just not flexible to go back down. It's not like, hey, I don't really drink, but I'll drink coffee. I'm drinking coffee right now on this podcast. And I have an interesting relationship with coffee. I drink coffee because it wakes me up a little bit. But if I drink too much coffee, it actually gets me a little bit too hyped up. And I will tell you that I believe that I'm addicted to coffee. So are we saying that my dopamine levels have risen by drinking the coffee, and now it's harder for me to get off the coffee, which it is. Because I'll tell you, every morning I say to myself, drink a little less coffee. And I don't drink less coffee. I have a cup of coffee every morning. I don't go crazy, but a cup of coffee. So is that related to my dopamine not being flexible enough to say, hey, you got to get off of it? That's why I'm having a hard time doing this?
I mean, possibly. We don't... When we do PET scans, they're very expensive and they're very time-consuming and they require a lot of resources. So we usually spend that on disorders that might end someone's life. For example,
fine.
Like alcohol dependence.
I'm putting alcohol in my. You know what? I'm putting Kahlua and alcohol in my coffee.
Got it. Right. So basically, yes. What happens as dopamine levels become more sluggish or less responsive, habitual behavior becomes harder to change. That's basically what I'm saying. And so you can think of it a lot of different ways. It greases the wheels, or it helps you. I'll give you an example from a research study. So we did a research study a number of years ago where we imaged cocaine-dependent individuals, and we looked at their dopamine levels, and then they all went into treatment. So we gave them 6 months of treatment, and we gave them very good, very effective behavioral treatment.
What kind of treatment?
It's called contingency management and community reinforcement approach.
Which is what in layman's terms?
So contingency management means that we actually paid people to stay clean. So they came into the clinic 3 days a week, and every day they were negative for cocaine, they earned money.
How much money, if you don't mind me asking?
They earned about $1,000 over 3 months. So it's not a huge amount of money, and it starts off low. Like it starts off, I think we pay them $2.50, and then the next time it goes to $5, and it escalates over time.
But enough incentive for them to actually change.
Enough incentive to stay, to not use cocaine and to do other things with their lives and to gain a little bit of money. Exactly.
Wow.
And then as we did that treatment, we also had to meet with a therapist who delivered a type of behavioral therapy, psychotherapy, called community reinforcement approach. And it's very, very basic. It essentially says you are engaging in this one particular behavior, such as buying cocaine, and you are not engaging in other behaviors, such as paying rent or seeing your mother on her birthday or taking your kids out to Chuck E. Cheese. You're not doing these other types of things. So how can we shift your behavior from doing something that in many ways is not even pleasant to you anymore and to do other things that are rewarding and pleasant to you? So it's a two-pronged approach.
It's pleasant in the beginning. It's anesthesia in the beginning,
but
then it goes away gradually.
Right. That's the thing. Off. By the time most people come to see a doctor for an addiction problem or come into a research study, it's lost the fun, right? But no one goes to see a doctor when they're first using cocaine and they're like, wow, this is great. I feel better than I ever have in my entire life. Can you help me? Yeah. People don't come to see the doctor until it's like
when it's not
it's
good.
No longer rewarding. It's no longer fun, and it's really become a problem, right?
Right.
So So we did that kind of treatment, which is very effective. Actually, it works in about 40 to 50% of cocaine users, and it actually works in other disorders as well. It works for tobacco. It works for alcohol.
And that's 6 months.
It was 6 months.
So every 3 months they get $1,000.
So the first 3 months they got $1,000. The second 3 months we didn't pay. So the second 3 months they're just going for the therapy. So the idea is to hook people in the beginning with the money.
Yep.
But then to have them continue as you reward them on a short-term basis.
Because they can't be paying. You can't keep paying them money to.
Right.
Right.
And as I said, it wasn't a lot of money. But what we're doing is we're sort of having them respond to a reward that's in the short term, small reward right here, right now. And then as we move through time, by the 6 months, they're focusing on rewards that are bigger, more abstract, and further in the future, like getting a job and taking your kids, to the beach for the summer, right?
Right.
So that's the idea behind the treatment.
So the first 3 months, you're paid. The second 3 months, what was that called? Community
reinforcement approach. The therapy goes the whole 6 months.
Right.
But we use a payment the first 3 months to get people hooked in.
Yeah, the hook.
And to keep coming.
But what exactly, the last 3 months, what exactly, break it down, what exactly are they going through? So, let's say I've gone 3 months, you've paid me $1,000. Okay, now I have 3 months to go. What do I have to do in order to finish this off and break the cycle of addiction? What do I have to go through?
So for the most part, the people who make it to the 3 month mark are doing well. And so for the second 3 months...
What's the percentage?
It's about 40%.
40% make it to that mark.
Mm-hmm. So about 40% of the people who made it to the 3 month mark were still doing well at the 6 month mark, all of them.
Let's be positive. 40% is better than 0%. So that's good. That's great.
So the important thing about this therapy is that, yes, an efficacy of 40% is tremendous. It's tremendous. And we don't have that in the regular... You can't... It is very difficult to get access to this treatment. So if you go to whatever rehab that you check into or community groups, for the most part, you cannot get this treatment, even though we've researched it now for 20 years or more, and we've shown that it's been effective.
Why can't they get the treatment?
It's a little complicated, but it basically has to do with the fact that in the late 90s, for the most part, the late part of the last century, 80s and 90s, insurance stopped reimbursing for psychiatric care and particularly addiction treatment.
How did I know it was going down this path?
Absolutely. It's all about public policy.
There we go.
And when Obamacare was passed, one of the major things that Obamacare has done, tremendous things that Obamacare has done, has made psychiatry be reimbursable, so now, and including addiction treatment. So now addiction treatment is covered by insurance.
Right.
The problem is in that period of time, we lost the people that would be treating it. Where would the treaters be, right? I mean, They don't have jobs. So what happened in the meantime is that even though we've studied these treatments, there aren't really people implementing them. So now that's why we have rehabs all over the place. I don't know about you. Maybe it's my search history on Google, but I am an addiction researcher. I mean, Google thinks that I need treatment and rehab every single day, and they try and send me to Port Jervis, New Jersey, or all these various rehabs. And you'll see they're advertised all over the place.
Oh, okay, gotcha. So it's your job to research this stuff, and they're actually the ads.
Google thinks I have a terrible addiction problem.
That's pretty funny.
Yeah.
No, Google thinks I have an addiction to something else, but we won't get into that. I type in one thing and it becomes
something else.
Yeah.
Right? Mm-hmm.
Listen, when you're married with 3 little kids,
you
get bombarded with certain ads, and that's the way it rolls.
Exactly.
But I'm not doing cocaine.
Right.
So
yeah. Right.
Things could be worse.
By far. So most rehabs now that have opened up don't use these proven treatments. Instead, they use 12-step, and that's all they use. And so, unfortunately, 12-step doesn't work for everyone. It works for some people, but not all. I personally have nothing against 12-step.
How effective is 12-step percentage-wise?
In general, about 20%.
Okay, so 20% for 12-step, and you're looking at 40% for these other ones.
Right. And the important thing is, so say 12-step works for 20% of people, good for them. The other 80, then put them into this other treatment. And, and then you save, another 40%. Wow. So, but we don't do this. We don't implement these treatments.
Do you specifically implement these treatments? Like if someone were to come to you, can you give them these treatments?
I don't. I only do research. I don't have a clinical practice.
Okay.
And my job in this study was actually the imaging I didn't do any of the treatment. The person who did the treatment knows what he's doing, and that's not me.
Gotcha.
His name's Ken Carpenter. He's a fantastic psychologist. He did all the treatment part of it. So we definitely had our different roles.
Okay, gotcha.
Yeah. So.
Yeah, that's neat.
I mean, there is a place in New York called Center for Motivation and Change that does offer these kinds of treatments, but outside New York City, there's not a lot of them. There is a movement to try and get rehabs to offer more of this, more alternatives to 12-step. If someone fails, I mean, the way we do things in this country, if someone fails 12-step, we give them what? More 12-step. And if they fail it, we give them more 12-step. And if they fail, we do it again. If someone has hypertension and we give them the first drug, we give them hydrochlorothiazide, and they fail that, we don't then give them hydrochlorothiazide again, right? We move on to other treatments and other medications.
What was it Einstein said? The definition of insanity is doing the same thing over and over again and expecting a change.
Exactly.
So 12-step, 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 12-step. Hello.
Exactly.
It probably not going to change after the first couple times.
Absolutely.
Yeah.
Right.
So let me make this. Let me understand this a little bit more. This treatment, which is very effective, 40% of it in the first 3 months after getting paid $1,000, works really well. But because insurance doesn't cover it,
you got it.
Insurance doesn't cover it, and that's all she wrote.
Pretty much, yeah.
That's a whole nother bugaboo. Different whole, yeah.
True.
That's a shame when you have something that really works like that. How can we change that though? How can that be changed? I hate to hear something like that, and then just be like, hey, oh well, can't have this treatment. I mean, why do we?
Honestly, the way it can be changed, the only way that it will be changed, is for patients who have an addiction problem and their families to know this information. And when they call up a rehab, ask for it. That's it.
Why are we here right now?
The honest truth is exactly. So if you have two rehabs across the street from each other, they're competing for patients, right? Because rehabs are now competing for patients. And you call them up and you ask if they have this treatment and they don't. You say, okay, I'm calling your competitor.
So I'm going to put you on the spot. For my listeners that have addiction problems with a variety of different things, go to where would they go and what are they asking for?
They would.
The power is in their hands, right? So the whole idea here is take responsibility for your own health.
Right.
Get the information. That's what we're doing. We're educating. We're empowering. We're entertaining. We're having fun here. So here's the information. And do what with it? Who do they call? Ghostbusters? Now, who do they call?
I mean, when they call rehabs, it's a matter of asking for these different treatments. So you can ask for a community reinforcement approach, contingency management. I mean, obviously they could have better names, right, than those. Those aren't so easy to remember. Yes. There's also cognitive behavioral therapy. It can be very effective. Other types of more limited approaches, such as relapse prevention or motivational interviewing. These are all techniques that can be implemented, and they can be implemented fairly easily. These treatments, for the most part, have been studied. They've even been manualized. So someone who's interested in learning how to deliver these treatments can get a manual from the government, from the National Institute of Health. It'll tell you exactly how to do it. It's like following a recipe. I mean, the research has been done to make these treatments more available and more consistently available through the community. But we haven't made that step yet.
So for repetitive, I like to be repetitive. For my brain, I like to say things over and over, and I write. Right. I'm always writing. It's expressive writing. So when I write, my brain remembers. Everyone learns differently. So for the listeners, again, it is to research the what two things?
There's community reinforcement approach.
Community reinforcement approach.
And that's often combined with contingency management.
Contingency management. I just wrote those down, and my brain remembers it. I'm a writer.
Right.
So I like taking pen, usually pencil, and writing on paper. And my brain remembers it. Not that you asked, but I'm telling you anyway. So there you go.
If you do go to the website, the National Institute on Drug Abuse, NIDA, NIDA website, they will have these listed.
NIDA.
NIDA.gov.
Is it what is it? Is it National Institute of?
National Institute on Drug Abuse.
On drug abuse. Okay, great. So that information is out there. Beautiful. That's good.
And
Give me a high five. That's
yep.
awesome.
I do have one other recommendation that I think is also very important.
It's going to cost you $1,000.
Okay, that's okay. It's remarkable to me that we have patient advocacy groups available for all kinds of disorders. I mean, sometimes disorders that are not very common and some that are very common. For example, the Michael J. Fox for Parkinson's disease.
Yeah.
We don't have anything on that scale for addiction. And it's remarkable, right?
Really?
We don't.
That's surprising.
There are groups here and there, and more power to them, that they're trying to build on this type of thing. But, Michael J. Fox funds all kinds of research for Parkinson's disease. There's all kinds of different, there's one for muscular dystrophy. There's all kinds of patient advocacy groups for breast cancer. But we don't really have anything like this for addiction. And that would also be a way of changing treatment options. That would be a real way of having a groundswell of people demanding that these other treatments become available.
I'm really surprised at that.
Mm-hmm.
Why is that? What's the deal with that? I'm really surprised. What? Nobody has stepped up and taken the reins? That's really surprising.
There is.
Are we looking for a celebrity? Who are we looking for here to take the reins?
I mean, for Michael J. Fox, it was a celebrity who set it up, and frankly, great for him. It's remarkable, actually, what that foundation has managed to accomplish. Sometimes it's not. For breast cancer, it was just some women started this group. So there's a lot of different ways it can start.
Yeah.
There is one called Shatterproof that is sort of in the beginning stages of trying to become a national advocacy group. But it's remarkable that we don't have a nationwide advocacy group that really tackles addiction and ways to treat it better.
Wow. I'm really surprised. I know I keep saying that, but that's it's such a major problem that I don't understand why there's not one person out of the gazillions of people in this world that would actually take charge. Hopefully that will change.
Hopefully that will change.
Yeah. We have to try to find that person.
We need that person, yeah.
Yeah, we do.
Yeah.
We can.
True.
We can. I say this in every podcast, and I'm going to say it again. Because I always want to make sure that my listeners know and that my guests know what I'm doing here. It's to educate or inform, which we just did. We now have some powerful tools on community reinforcement approach and contingency management. I mean, that right there alone, I've never heard of it.
Great.
And most people probably have never heard of it because it's not that out there. I know the 12-step approach.
Right.
I've never had a problem, thank God, but I know
it's everywhere.
It's everywhere.
Yeah.
Okay, so we've done that. We empower, okay, with our positive energy. Try to get people to go out there and find that information. Take charge. Here's the information. Go do something with it.
Great. There's also a foundation called the Smithers Foundation that is actually working on this as we speak to try and improve treatment options available to patients.
Smithers? Okay.
Smithers Foundation. It's Christopher D. Smithers Foundation.
All right, good. Well, we're going in the right direction.
True.
Yeah.
Finally.
I
mean, how long addiction has been a problem.
I know.
Yeah.
So let's veer off into another subject.
Okay.
Speaking of addiction, something that's very controversial, medical marijuana. And this was not on my list of things to talk to you about, but you sent me a text message saying medical marijuana. So that tells me you have something on your mind.
Well, as an addiction researcher, of course, I follow all kinds of things closely, including medical marijuana. And, the thing I try and make clear when I give talks sometimes to parent groups at my son's schools, sort of about these different topics. Well, addiction, right?
Yep.
And I try and make the case consistently that addiction is not about the particular substance abuse. It's about the substance of abuse and the person taking it. So, for example, there are a number of studies actually showing there's maybe 4 or 5 studies, they're not huge, but showing that nicotine patch is helpful for cognitive impairment and Alzheimer's disease, which frankly is pretty remarkable. Do you know how many things we've tried to try and do something about Alzheimer's disease and have failed? Many things have failed, but a nicotine patch is actually remarkably helpful.
I can't remember.
So, exactly.
What was that again?
So
Maybe I'm in the early stages.
Maybe you are. Maybe you could try a nicotine patch.
You might have to take over this podcast.
Okay.
That's interesting. Seriously.
Right. So, but so a nicotine patch in a patient with Alzheimer's disease, is that a problem? Probably not. If you gave a nicotine patch to an 11-year-old, is that a problem? Most likely. So addiction is about who's taking the drug, not just the drug itself, and the pharmacology of that drug, combined with the brain that is being exposed to it. So that's basically the issue with addiction. Now, when it comes to medical marijuana, there are definitely some advantages to marijuana. THC has been shown to be effective for pain relief, spasticity, and chemotherapy-induced nausea and vomiting are the main things that it's effective for. And for pain relief, it's about as effective as codeine, which is not spectacular, but it's remarkable. I mean, to have something that is a non-opioid that's as effective as an opioid is pretty incredible.
But is THC addictive?
THC is addictive depending on who is taking it, right? Just like nicotine.
Because some people are more addictive right. type people than others.
So when we talk about something called addiction liability or capture rate when we talk about addiction. And so the capture rate is the percent of people that are likely to develop an addiction to a particular drug who use it. So for example, a capture rate of 100% is everyone who used a particular drug would develop an addiction to it. 50%, half the people develop an addiction. So the capture rate for marijuana is 9%. So about 9% of people who use it will become addicted. Now that's lower than alcohol.
Marijuana with the THC.
With THC.
Because it could be only CBD.
Right.
It could be
marijuana with CBD is likely not addictive.
We're talking the THC.
Absolutely.
Okay, so only 9%?
9% of adults. Now that number goes up to 17% when we're talking about adolescents.
That's interesting. Right? Okay.
And
why are they getting to this level? Why are they taking the medical marijuana in the first place? What's the...
So, I mean, I would say most people taking medical marijuana probably do not have an addiction problem. The addiction problem is largely going to be people using it recreationally or who start recreational, right? Because by the time someone gets to medical marijuana, I mean, it depends on the state. It's different, obviously, California. But usually by the time someone gets to that point, they're ill. And so they're taking marijuana for reasons that help their illness. As opposed to, and honestly, most people, when they become addicted to a particular substance of abuse, it's because they use it early on. So people don't normally
early on
in their lifetimes.
In their lifetime,
right? Like teens, 20s.
Teens and 20s.
Right. Like you almost never see anyone who has an addiction. I mean, I see addicted people all day long.
Yeah.
In my research studies, almost everyone's in their 40s and 50s. You rarely see people younger than that. Sometimes in their 30s with alcohol. And, no one comes to me and says, oh, I started drinking at 32, right? Like, that's not what happens. They all start drinking at 12. Or, the latest, like, 22.
How does that happen? God, how does that happen where people get addicted in their teens? Is that parent oversight? The parents aren't around? Let me just say this. So I have a friend, Dr. Raj Juneja. He was also on the podcast. He said some very interesting things. He said everything stems from trauma in childhood, and that the addictions that he deals with, and he deals with opioid addiction, it all stems from little T's and big T's. Little T's, little traumas, big T's, big traumas. Daddy didn't watch my baseball games. He never came to my baseball games. He wasn't around. Mom was always in the kitchen, didn't pay any attention. They were indifferent. Or, I was hogtied and abused. And in his mind, that's where addiction stems from. Would you agree with that?
I mean, I would certainly agree that a history of trauma in childhood certainly makes you more vulnerable to developing an addiction. But I don't think it explains all of it. There's also genetic factors. There's also... So I'll use myself for an example. I have family members that have addiction problems, and I personally don't. But I think the main reason I don't, growing up in Texas, is because if I drink more than 2 beers, I'm throwing up. So even though I might have an addiction predisposition to addiction based on my genes,
Yeah.
something happened in my brain, the area postrema, which is the area that's in control of vomiting, is super sensitive. So I never really, I never get to a point where.
So in a way, you got a little lucky.
So I'm protective, right?
So you
why am I protected?
potentially could have had
It
that
could have
same
potentially
issue.
gone the other way, right? It
Yeah.
could have potentially. So I don't think you can always necessarily. We don't know exactly what makes someone more vulnerable, and certainly, a history of traumas does. But there are other things that can be involved as well. Certainly genetics, even epigenetics. For example, kids who have attention deficit disorder are more likely to develop an addiction if they're not treated. They're more likely to become smokers. They're more likely to use almost every different drug if they're not treated. So, attention deficit disorder, like, is that
Yeah, I'm
genetic?
still
Is that
trying to. I am still
childhood?
trying to figure out what attention deficit disorder is. I really am. ADD, ADHD. I am really trying to figure it out. Is ADD and ADHD? Is that, hey, he's a young boy and he's got energy? Is that ADD, ADHD, or the kids get? Such a gray area of what this is. I mean, you could go to. Listen, I was diagnosed as a young kid with ADD and ADHD. I'm not totally convinced that I had ADD. I just think I was a young, energetic boy who didn't want to sit in a traditional school and be slapped to the desk all day and get only 20 minutes of recess and not a lot of food. But I'm going off on a tangent here, but it's... You know where I'm going with this.
There is, but there's a spectrum. There's always a spectrum with almost every disorder.
Yeah.
And so, people who are in the mild camp, like, where do they fall, is always going to be unclear. But there are definitely people in the severe camp who, treatment can be really life-saving. It can really convert a kid from having, like, terrible problems at school and problems doing homework and problems, about how they see themselves into someone who can flourish. So,
Let me ask you this. So, having 3 kids myself, and my listeners, most likely they're moms, and moms are always moms. Moms are concerned. They're concerned about their kids, and they want the best for their kids. To me, I don't even want to get to this point. How do you even avoid these situations? Let's just say that you do have kids that have ADD or ADHD. Let's just say some of these genetic predispositions are there.
Mm-hmm.
What do you do to avoid any problems?
I don't know. I don't know the answer to that. I don't know, I see patients frequently with addiction problems, and I certainly sympathize with the parents. I would never say to a parent, this is all your fault, right? These things sometimes just happen. And as parents, the best thing you can do is try and work around it, prevent what you can and treat what you can't.
Right.
So,
What's the it's scary.
it is. Yeah, having kids is terrifying, that's for sure.
It is. It's I all I can think of is like keeping my kids busy, keep them in school and educated and away from drugs. And I'm being sincere, it scares the hell out of me. I said this with Dr. Junasia, and I'm saying it again. I don't want to be the parent that is constantly up the butt of my kids. I want them to have some free range. I want them to make their own decisions. I can't do everything for them. That being said, with all the drugs out there and the epidemic that we have, especially with opioids, it makes me want to just like, hey, you're not going over to this person's house, or hey, like, you're not going to this party. I've heard enough already. I really have. I've heard enough already where it's like, that's it. And what do you do? I guess that's the big question. Well, what did you do? You have older kids. You mind if we talk about, like, you have older kids? Can we?
Sure, I have an 11-year-old and a 15-year-old, almost 16.
So what have you done to?
So with my 16, both my kids, frankly, know almost everything you could possibly know about different drugs and their effects on the brain and how they impact the mind and the body And they are very aware that, one of the problems with substances of abuse, and by substance of abuse I mean drugs and alcohol, one of the problems is that they all have effect on the brains that people like. They make you feel less anxious, less stressed. I mean, nicotine or tobacco is remarkably good at relieving stress and making you smarter. People function better oftentimes when they're smoking, right? The brain moves, their cognition improves. So, of course that becomes addicting, right? And so you have to remember that every substance of abuse has some sort of a positive effect on the brain.
Right.
People wouldn't bother taking them otherwise.
Right.
So
it's just temporary.
Well, it actually, for a while, and then it gets the better of you with time.
Right.
So with my kids, I just, they know all about the drugs. They know what they do in the brain. They know the risk of addiction. They know what to do, if someone has an addiction problem. They, I try and make it clear to them, especially my 15-year-old, that in the human brain, there are really two important events that happen. And for you and I, those events are long gone, unfortunately. But
speak for yourself.
Yeah.
I feel like I'm getting better and better every day.
Well, maybe subtly.
Hey!
But
you know what? It's a positive mindset.
It is a positive.
I have my days where I'm like, oh boy, you know what? I played basketball last night and I didn't bounce back like I used to. But positive mindset.
Absolutely.
You have a positive mindset.
I do have a
the
positive
mind
mindset.
And the body, the gut and the brain, we work together.
True.
You're not bringing me down, Dr. Deanna.
I'm not. Okay.
We're lifting up.
We are.
I'm just kidding. I'm just kidding.
So in the brain, there's two important events. The first is infancy, right? The brain is growing, and that's why kids have such big heads, and all these networks are forming, and that's why how kids are learning to walk, to talk, to do math problems, to ride a bike, to speak another language. All these things are happening. And then what happens though in the teenage years is that the brain starts pruning. It starts reducing some of these networks. It starts selecting the most used networks so that it becomes more efficient. That's what the brain is doing between the ages of about, say, 13 and 20. And so we get back to habitual behavior. But this is what I do. That's when habits form. Because as the brain is whittling
13 to 20.
Between 13 and 20, all these things that you've learned, that's when they're going to become basically in your brain for the rest of your life. That's why if you want to learn another language, do it while you're young, right? We all know that. Same with riding a bike or learning to swim. All of these things have to happen early, and then the brain starts
My wife's Polish.
Uh-huh.
My kids speak Polish, and they pick it up lickety split,
right.
And I am brain dead.
Exactly.
It is
because
so hard.
You're past that point.
You're right. All right, fine. I'm past that point. It is so hard for me to pick up Polish. I try hard.
Right.
A for effort. I get about a D for execution. But my kids, to your point,
right, they pick it up.
They pick up Polish.
Exactly.
And Polish is a very hard language.
Right.
This is not like Spanish. It's hard.
Mm-hmm.
Boom, they pick it up.
Right.
So
what I say to my 15-year-old, these are the time in your life where you are forming your habits. Choose wisely. Do you want those to include nicotine or alcohol? I don't think you do. You want those things to include. These are the things that are going to be with you. These are the behaviors that will be with you for the rest of your life.
So you have really, it's what you do, it's your job.
Right.
So it sounds like you have really just educated them time and time again.
As much as I can.
And to the point where they just know the deal. They just
deal.
know it.
They do.
From repetition.
They know that if you're over the age of 21 when you start drinking, you're less likely to become an alcoholic.
Yeah.
Yep. They know
13 to 21.
Mm-hmm.
Yeah.
20, 21, Exactly.
I'm not there yet, but 13 to 21, I'm going to...
And frankly, the other thing I tell my 15-year-old, I'm like, drugs have been around forever, and they will be around forever. The cockroaches will be drinking alcohol at the end of the world, right? Drugs are going nowhere. You have your entire life to experiment with these if you want to. But if you do it, the later you are, the less likely it is to be a problem for you. So just wait. What's the harm in waiting?
I'll just lock my kids in their room for 8 years.
Yeah, that doesn't really work. So because they have to negotiate the world. So,
no.
Yeah. So I do a lot of that. I do try and educate my 15-year-old and his friends. I talk to them very openly about drugs and alcohol, the effects on the brain, and all these different risk factors. The more you know, the less likely you are to get in trouble. My kids know that you can overdose on alcohol, and it happens all the time. And overdosing on alcohol, I literally mean overdosing on alcohol. You drink so much alcohol that it shuts down the brain and you stop breathing.
Yeah. Do you, and I know you talk to kids, do you talk to schools?
I do. I actually, next week I have a talk at my son's school,
At
his
your
high
son's
school. About, and a slideshow presentation
But
about.
don't be greedy though. Don't be
I
greedy.
am
Because
more-
now you're such a superstar that I feel like I need to rope you back in to come out, pick you up at the train station again. We'll get you. Can I bring you into our school district?
Absolutely. I am more than happy to talk to any parents group, any school district about this information. And, I think the more you know, the less likely you are to get in trouble.
Yes.
And the more likely you are to make the best decisions that you can in life. And that's just what kids have to learn.
That's great. I think we got to get you back to.
Sure. I'd love to. It's
Talk-
one. I do neuroscience research all day long, and it gets very technical, and I do a lot of spreadsheets, and I write a lot of grants, and it can be very technical, and frankly, I hate to say it, it gets a little boring sometimes.
No.
But this is a way, like talking to patient advocacy groups or talking to parents groups, actually, I find, refreshing. It's really a lot of fun for me.
Yeah.
And one thing that I've realized is that, in research, in addiction research, we've made a lot of inroads. We know a lot about the neuroscience. We know a lot about epidemiology. We know a lot about who gets in trouble, who doesn't. We know a lot about new treatments. We know a lot of things, and we don't communicate it properly to the community. People don't know what we do.
Well, you know what I think the key is, and this is where I think I do well. I don't do well in some things, but I'm kind of a child myself, so like I'm at that level. If you make it fun. Like it's kind of like school. Like you go to school, and you get out of school, and you throw the papers up in the air, and you're like, "Yeah, school's out for summer."
Right.
Remember that song?
Yeah.
Like it shouldn't be that. It doesn't need to be painful.
Right.
With painful math worksheets, sitting at the desk, and I mean this sincerely. It does not need to be painful. It shouldn't be a chore.
Right.
So with you have so much knowledge, and you're starting a podcast, and I'm going to push you to do this podcast.
I'm going to work on it.
Okay, Dr.
Yeah.
Deanna Martinez is starting a podcast. I'm going to help you get this thing up and going.
Great.
And people are going to listen to it because you have an incredible mind. You have so much in there to share. Just make it fun. It's just put a little twist on it.
Right.
It's like you remember the Bueller. What was that? Ferris Bueller's Day Off.
Oh, right. Yes.
You remember that guy? He had that monotone, and it was like, like forget it.
Right.
The information that's coming out of his mouth is great information, but you're not processing the information because the guy's putting you to sleep.
Right.
But if you're jumping around and acting like a hooligan like I am, maybe you're like, what the hell's going on here? I remember he was, acting like this and saying this and bring a little spark to it.
Right.
But yeah, you have so much information, and that's awesome. And listen, I just learned a lot.
Great.
And part of this,
That's my goal.
My listeners, I just learned a lot. Now I know, and I didn't know this, 13 to 21 is the time period. I always teach my kids as much as I humanly can teach them. I always try to teach them the main things, which is cognitive thinking, sleep, nutrition, exercise, relationships. Those are the 5 principles in my mind. But now I know. 13 to 21, I really got to step it up and be aware that I keep reinforcing, hey, this is what's going to happen when you do this. Make the right choices, hang out with the right kids, and you'll be successful. And if not, you'll end up. This is what can happen.
It can.
Yeah.
My kids know the older you are, the better it is. The longer you wait, the better it is in terms of preventing addiction. Now, if my 13-year-old were drinking alcohol, believe me, that's a huge red flag. If my 19-year-old goes to a party and drinks alcohol, it's going to happen, and I get that. But what I'm more worried about is if he drinks that alcohol, so one of the things that strikes me in addiction research is that when I talk to people about when their addiction first started, they all say the same thing. They say, I finally felt normal. people who drink alcohol,
They felt normal
they
when
felt
they
normal
started.
when they started using the drug. So they drank alcohol. There's a great story about Bill Wilson, the founder of AA, how he didn't drink alcohol until he was about 21 because he lived in a dry state. And he drank alcohol at a party, and he finally felt a part of things. He finally felt normal when he was intoxicated.
Why is that?
That is what happens. The majority of people, when you talk to them, when they developed an addiction, whether it's opioids, whether it's tobacco, whatever it is, they say, I finally felt normal. And that is a huge red flag. And my kids know that as well. Like if they go to a party and they drink a beer and they don't feel normal, they feel intoxicated, they might feel relaxed or whatever, that's fine. But if they feel normal, that's really a real big red flag.
Oh, we got to talk about this. But no. That's cool. So that's confusing. Why do they feel normal once they start getting on these?
Frankly, I'm a big believer that when people start consistent drug use, it's because it's doing something. It's doing something that their brain isn't doing naturally or endogenously.
So
right?
there's an issue prior to that.
Right. I mean, we can call lots of times people call it self-medication. You can call it self-medication.
Is this the ADD thing?
It's not necessarily, people who develop an alcohol problem often start off, it's enjoyable, but, alcohol relieves stress. They finally feel normal.
Right.
I mean, it's something is happening in the person's brain that is taking away or adding in a way that they feel that they're functioning better. Right.
But something must have been missing prior to drinking alcohol or taking the drugs in order for them to feel better.
Right.
So I guess the question becomes, and you said that the ADD and ADHD, there's a higher likelihood of addiction. Correct. So is the ADD and the ADHD, is there something that is the chemistry of the brain off? Is there something off in the brain that needs to kind of be fixed when you drink? So maybe like when you drink, it's like, oh, now I'm regulated. Now I'm good.
Right. I mean, we know from PET scans that there are changes in the dopamine system that occur in ADD, and we know that they're similar to those seen in addiction. So it all comes back to dopamine.
I'll come back to dopamine. It
always goes back to dopamine.
Watch what you call me. Do you talk to your mother with that mouth?
Exactly.
Come on. You're on my show. You can't call me names. Wow. It all goes back to dopamine. All right.
At least, in my world, that's what I image. So it all comes back to dopamine. But dopamine does play into it significantly.
Is there any way, I'd like to put this up. I want to see. I'm very curious. Ming, could you please, if it's okay, pull up, is there a place where I can pull up a scan of a brain that has been on drugs and a brain that
sure.
has... Like, is there one in particular? So for my listeners, I'm going to try that on YouTube. I will put this slide up there because I want to see, I'm visual. I want to see... So Dr. Deanna, which website should we go to?
There you go. Right there's what is that? Let me see.
So what we're doing is we're pulling up slides
there you go.
Of a brain not on drugs and a brain that is on drugs. I want to see the difference. Okay. Those are purple brains.
Yeah, those are I'm fairly certain those are D2 receptor, except for the smokers, I'm not entirely sure. But if you look at the last column, see where it says cocaine and normal? There you go. That's imaging dopamine type 2 receptors, and the levels are lower of D2 receptors in cocaine.
So what am I looking at? There's one. Which ones am I looking at?
So if you look at cocaine and normal in the last column, those two, right there.
Okay. So the top is cocaine.
The top is cocaine.
Because I don't have my glasses on. I'm going blind.
Okay. And it's similar in the alcoholic column too, but we'll just focus on cocaine right now. So cocaine and normal. So this isn't a scan, a PET scan looking at dopamine receptors, dopamine type 2 receptors in the brain. And the brain region that mostly lights up is called the striatum. It's made up of the caudate and putamen. And
it's different, but it's not as different as I thought it would be.
No, these changes are not huge.
Yeah, I was expecting a big difference. There's not much.
No, the differences are not huge. They're small. They're on the order of 10 to 20% differences between normal and cocaine-dependent brains.
Right.
Right.
But there's differences.
Right. That's all it takes.
That's all it takes. That there's obviously they're doing something. Again, I was just surprised that. There's that like little black stuff on the bottom there. Well, we'll get those slides up because I want you can watch this on YouTube. The Whole Truth Podcast with John Levine, Dr. Diana, not Diana, Dr. Diana Martinez. It was awesome having you on.
Great, thank you. It was fun to be here.
Yeah, thanks. Let's do it again. I
Definitely.
need to get you to talk to my kids because they don't listen to me. Maybe they'll listen to you.
Exactly.
And we got to get you into the school system too.
I would welcome that.
I could tell you're very passionate about what you do, and you're very nice.
Sure.
You're very sweet. I also always say this. There's this. Being a good doctor is not always knowing what you're talking about. It's also the bedside manner, and you have that.
Thank you.
Because when you go into a doctor, you need to feel comfortable.
That's very true.
And I feel very comfortable with you.
Excellent.
Can I give you a hug?
Absolutely.
Okay. You going to give me a hug? All right.
If I can reach.
All right. Yeah. Come on. Give me a hug. Bring it in. Thank you, sweetie.
Absolutely.
Really appreciate it.
Excellent.
Thank you so much, Dr. Diana Martinez, for being here with John Levine on the Whole Truth Podcast with John Levine. And until next time, we will talk to you soon. We will see you soon. It's been real.
Absolutely. Thank you for having me.